So we're going to continue the great conversation we just started with the Congresswoman, and we have an amazing panel to address this from really all different aspects of brain health. And I'll just introduce them briefly. Dr. Ruth Benca is professor and chair of the Department of Psychiatry at UC Irvine, where she established a sleep medicine center. So, of course, as the parent of a young baby, I am asking her for lots of advice about how my brain's going to be affected from my sleepless nights in the future. Dr. Marie Bernard is the deputy director of the National Institute on Aging and the Institute's senior geriatrician, in an institute where I'm sure there are many, many geriatricians, the most senior. Dr. Rod Hochman is CEO of Providence St. Joseph Health and incoming board chair of the American Hospital Association. Nora Super is the senior director of the Milken Institute Center for the Future of Aging and is going to tell us a little bit about the Institute's report out on Alzheimer's this morning that just was released. And Dr. Rudy Tanzi is the vice chair of neurology at Harvard and MGH, which is just one of his many titles. A fun fact about Dr. Tanzi, if you all don't know, is he's an incredible musician and he plays the piano for Aerosmith. So he somehow finds time to do that. He told me before we went on that he's on call, and I thought he meant as a doctor, and he meant he is on call to go on the road with Aerosmith to play piano for them. So, Nora, why don't you kick it off for us, because your report just came out this morning, and tell us some of the highlights of it.
Great, thank you, and thank you so much for everyone to be here. It's really wonderful to hear from Congresswoman Maxine Waters about the work they're doing in Congress and what's happening in brain health. We updated a report that we did in 2016 on the price of dementia on women because of the disparities between men and women and prevalence of dementia and Alzheimer's. And in just 3 short years, so much has changed, which I think is really hopeful and helped us decide to release this report, which you should all have, focusing on reducing the cost and risk of dementia. And in this report, the full report's on our website, we have many recommendations, actionable recommendations that we think will move us forward to improve brain health and reduce disparities. It will take all of us to work on this. We are still committed to finding a cure to Alzheimer's. We've heard some good news recently on that. But in the meantime, we really need to point people in the right direction about what they can do to improve their brain health, reduce their risk, and really, and then also work in our delivery system to train our health professionals as well as the caregivers, as Congresswoman Waters talked about the strain and stress on them, to help them better care for people living with dementia so that they can get the right care at the right time. And finally, to make our communities and our workplaces more understanding and open to people living with dementia as well as their caregivers. So we're really excited to be here as part of this great panel and have you all join us to work on this, really one of the biggest public health crises facing our whole world right now.
And so what I'd like to do, actually, is just have each panelist from their own sort of perspective, and I'll start with Dr. Tanzi, give us kind of a status report. Where do we stand as a society in preparing our own brains, in preparing for the onslaught and what we're already facing of dementia as we age? How are we doing?
Well, I think this is a very exciting time to be in Alzheimer's research, most exciting time of my life, really. The elephant in the room has always been that we don't diagnose Alzheimer's, the most common form of dementia in the elderly, until the brain's degenerated to the point of dysfunction. And I say, imagine if we did the same thing with diabetes. Imagine if we waited till the pancreas degenerated to dysfunction. We say, okay, now you have diabetes, now we're going to try to help you. So I think that, the mantra of early prediction, so developing better polygenic genetic risk scores, so you know when you're going to have to start really thinking seriously about early detection, the second part of the mantra. And now we have digital technologies, AI coming in, we have imaging, we have a blood test coming soon for amyloid in the blood, so that's moving along. But most importantly, we want the early detection to be actionable, so people will use it. And actionable means early intervention. And for quite some time, we thought it was going to be amyloid plaques, and then we had a bunch of negative trials, and we said, well, the amyloid comes very early. If you want to help the brain, you have to stop the neuroinflammation. And all that's still true, but I think the news from Biogen that we might get into says hitting amyloid plaque very early also has a lot of promise for helping stave off this disease. So many different ways to do it, but we have to start early, and we have to know our family history and when we have to get going with early detection to beat this thing.
Dr. Hochman?
Sure. From my perspective, running a large health system, we take care of 16 million people a year. And the question is are our health systems ready for what we're talking about? Answer, no. I think what we're trying to lead with the American Hospital Association and others is how do we create age-friendly health systems? And with age-friendly health systems comes the understanding of particularly the neurodegenerative diseases and what's the right environment for them. Today, in a health system like ours, more than 50% of the work gets done at home or in the ambulatory setting. And we look at the future for particularly neurodegenerative diseases of creating the health system of the future to care for people in their own environment. And then with the digital revolution that's here, how do we create that digital revolution so it works for the families and patients and for the caregivers in a way that lets them really care for this population the way they need to? So that's what we're spending a lot of time and energy around the country trying to really recreate what the health system of the future looks like, particularly for patients like this. And then on the clinical side, we look at, besides just what we're talking about on Alzheimer's, how do we preserve brain function? One of the things that we're very active in is in the whole telestroke program. Because if with micro and macrovascular disease, you want to talk about saving brain health, we've got a lot of work to do in that whole area. And then in the detection, early detection, as we've talked about, is critically important.
So I represent the federal government. I'm at the National Institute on Aging, one of the 27 institutes and centers of the National Institutes of Health. And that large increase in funding that Representative Waters mentioned came to our institute. We are the federally designated lead in Alzheimer's research. And it's been really gratifying to see the growth in knowledge, not only with that, but in the last decade. My other life, as was mentioned, was as an academic geriatrician. And back in those days, just a decade ago, in order to make a diagnosis of Alzheimer's disease or to really truly detect significant changes in a person, you'd have to wait until they died. And you had to do an autopsy and see what changes there were. And now, as a result of the research that has been enabled by the increased federal funding, we can look into the brain as things are developing. Yes, we have a lot of different potential targets for intervention and treatment long before a person has symptoms. Yes, we're beginning to find things like perhaps blood tests or eye tests or the way that people drive that will give you a sign that they are developing significant cognitive impairment, possibly the development of Alzheimer's disease. And we're able, as a result of the very generous additional funding, to also support projects that will look at how best to go about the care and caregiving of people living with dementia, to go about the early detection and potentially the generalization of the results of studies that looked at how to go about preventing this. So it's really, quite honestly, a very exciting time for the science of brain health and Alzheimer's disease.
Well, as a sleep clinician and a sleep researcher, I think this is also an exciting time because we're starting to understand how important sleep is in actually preventing Alzheimer's. We have mounting evidence that sleep disorders and insufficient sleep contribute to risk for Alzheimer's decades before people develop the disorder. But I think even more importantly and more exciting is the fact that we're now starting to understand how the sleep-wake cycle is critically important for the production and the processing and clearance of some of the toxic substances that cause Alzheimer's, like amyloid and tau proteins. And so it's not just that we should be all getting more sleep, which many of us don't do, and taking care of sleep disorders, but we now understand that specific sleep brainwave patterns are important for learning and memory function, as well as for clearance of amyloid and tau. And we actually have tools now where we can manipulate these brainwave patterns during sleep. So it's not just to try to eliminate the problems or sleep as a lifestyle intervention, which it is, but also that we may actually have tools very near at hand where we might be able to impact on Alzheimer's pathology in a positive way while we're working on finding that cure.
On sleep, I think everybody might be interested in this topic because 90% of us probably where we don't get enough. How much sleep do we need to be getting, or is it different for everyone?
Well, it's a bit different for everyone, but we're not all short sleepers. People like to think that they can get away with 5 or 6 hours of sleep. The epidemiologic studies suggest that people who report getting around 7 hours at night have the lowest health risks. There are some people who need a bit more, a bit less. But when you start getting to the extremes of sleeping significantly more or less than 7 hours a night, that is associated with increased risks of many disorders, including Alzheimer's disease.
All right, we should all be going to bed earlier, I suppose.
Right.
Let's talk about the recent news, which was just last week, of the Alzheimer's drug from Biogen, aducanumab. This was a drug many people probably know that in March the company said had failed in clinical trials. It was going to stop development of the drug because an interim analysis suggested that the trials were going to fail. They subsequently got more data on more patients and said last week that the analysis they had originally done was wrong and one of the trials succeeded. The other trial still failed, although they said there were signals in the high dose that suggested the drug was working. This is a drug that targets the amyloid plaques in the brain, and they said that there was a result on slowing of the cognitive declines associated with Alzheimer's disease. I want everybody's opinion here, but do you guys think the drug works based on what you've seen?
I'm biased because I discovered the amyloid gene a long time ago, and about 15 years ago we found these naturally occurring autoantibodies in the blood that saw a particular form of amyloid called an oligomer that was protective against Alzheimer's. So the more this antibody you had, the more your age of onset was pushed out. And Roger Nietzsche out in Switzerland very wisely went after that, what that antibody was, and that turned into aducanumab. And so we were so disappointed when the futility analysis said it was negative. But the thing was, and originally, if you carried an ApoE4 risk allele, you couldn't get the high dose because it was more likely you were going to have edema or some swelling around blood vessels in the brain or even microhemorrhage. Then when they saw that that was mostly resolvable, even if that happened, they allowed the higher dose to be used in more patients, because 60% of patients are E4, and that happened in 2017. So when the futility analysis came in, yes, it was negative, but many of those higher dose folks hadn't finished yet. And then at least in one of the two trials with a higher dose, there was a significant improvement. Improvement here means if you're going downhill on the black slope, they put you on a blue slope, which is still better than nothing. And in some of the other mental memory tests they did, they put people on a green slope. But the one the FDA likes was the black to blue. So I think that it says you have to hit amyloid very early. I think if you look at the amount of improvement they had, at least in one phase 3 study, and if you look at the precedent for how Aricept and other current Alzheimer drugs were approved, I think there's a good chance they will get approved. But the big question will be, if there are 38 million people in this country that have amyloid in their brains without symptoms and they're all clamoring for a therapy to bring it down, who gets a drug that costs $5,000 a month? So, even if there's approval, the commercial part of it and getting it out there. So I think it's really going to more open the door for cheaper, safer, regular little white pill type drugs that are in development that will hit amyloid early on. But it's all good news, I think.
I want to talk about the implications of a drug like this potentially getting approval, but before I do that, anybody else want to weigh in on whether they think it works from what they've seen so far? Nope.
I mean, I will certainly say that we're interested in seeing the full data. We've only seen the announcement thus far, and I understand that the full data will be presented at a meeting in December, the Clinical Trials in Alzheimer's Disease meeting. We certainly think that there is a role potentially for drugs that target amyloid, and we have a number of clinical studies that are ongoing now that are looking not only at people with mild cognitive impairment or early Alzheimer's disease, but people who are truly pre-symptomatic, who may have changes within the brain that are not associated with symptoms. And some of those trials will have results coming out in the very near future. So that'll be very interesting to see.
Mm-hmm.
I think the only danger is that I think Americans always want to see the one shot to cure something. And I think what we're going to learn with all the neurodegenerative disorders, that it's like where we were with cancer. It's multifactorial. We shouldn't just kind of go, oh, if I just take this pill, I'll be okay. Because I think what we'll hear from all of us, that there's many other factors that need to be addressed along with it. So I think that's the balance that we want to make sure that the public understands.
And I should add that, we very much endorse that, and thus we have a multitude of targets that are being looked at in terms of clinical trials to try to make a difference for this amyloid being among them, but it's not even the majority.
Right.
The only thing I'd add is I'd echo Dr. Tanzi's point about it being positive news, because I think even when I was at a conference last week at Us Against Alzheimer's, the news broke, and there were many physicians on the panel with me as well as today. I'm thinking all of you in med school probably missed sleep. But anyway, what the doctors all said was this is going to be huge in terms of people going in to see their doctor, and more emphasis on screening, early diagnosis. And so I think there is that risk, everyone clamoring for the drug, but one of the things that we really recommend, and everyone has said, is early detection is really important, getting some treatments early on, and there are definitely lifestyle factors we could address today, but I think making people more aware and going in and have regular cognitive testing is incredibly important to future brain health for us.
Mm-hmm. Did you see?
I just want to say, I think it's great that while many private foundations ran away from amyloid after reading the Wall Street Journal about failures, that the NIA did not. They stuck with it, and they said, we'll keep the amyloid studies going, but we'll also look at alternatives. And I think now looking back, it's a good thing, because if we need other drugs to hit amyloid early on that are more economically feasible, that are safer to use, those are in the pipeline thanks to the NIA and to the increased funding. So that's another reason to be optimistic.
Dr. Hochman, running a hospital system, what do you see as the implications of a potential drug like this reaching the market? It's an infusion, so it takes new infrastructure potentially to administer a drug like this. If the data are not extremely clear that the drug definitely works and definitely works for everybody who might want it, how do you see that getting approached? And I know you don't speak for the payer side, but how do you see that getting paid for?
Well, I think that's the number one question. If you look at the crisis in healthcare today, it's about affordability. And I think we've maxed out the credit cards and everything else in the country, and we'd say, where do we spend what we have? So I think there's a real movement to say, what are the most effective? And some of the pushback on pharma is that you've got to demonstrate efficacy, and you've got to be able to demonstrate either an improvement in someone's lifestyle or longevity. And I think there are too many Me Too's out there. And if you look at the one area that's the fastest rising cost in the whole healthcare delivery system, it's really pharma. And whether you're a payer or whether you're a provider, we're trying to figure out how to deal with that. The delivery of it isn't hard. We deal with infusions all the time. But the question is, if it's for everyone, how do we pay for it? And I don't think we have the answer to that.
Mm-hmm. Pharma would dispute your argument that they're the fastest rising costs. I think they like to say they're, 14% of overall healthcare costs.
But their curve is on the steepest one. And we've just dealt with the whole generic drug issue with Civica RX, saying we need some a counterpoint to that. But they're the fastest. I would say the rate of rise is the fastest.
Dr. Bernard, you mentioned, or actually Dr. Tanzi mentioned that the National Institute on Aging has been a supporter of Alzheimer's amyloid research, but also of other areas. And I know Dr. Collins, the director of the NIH, has said, yes, amyloid is something we should pursue, but we need to be open-minded about other ideas too. What else are you seeing that's exciting in terms of this kind of research?
Oh, there are so many different targets that are being looked at in terms of preclinical studies. There are targets such as tau, synaptic transmissions, neuroinflammation, vascular changes, viruses, multiple other targets. When we step back and we look at it, I think we have 40 or so projects that are looking at a variety of targets, and maybe 15 different targets for each of those in the preclinical space, and then we have some that are further along. Can I pick what I think is most exciting? I would certainly say it's been very interesting to see the resurgence of interest in viruses, and that came about as a result of public-private partnership called the Accelerating Medicines Partnership Alzheimer's Disease Initiative. It brought together pharma and academia and philanthropy and the government in a pre-competitive space to look at what happens with genes and proteins and systems in Alzheimer's patients, and looked at the brains of those. And from that analysis, it was observed that herpes virus seemed to be more commonly associated with the brains of people with Alzheimer's than in others. And so it had been a theory some time back. Now people are, again, really interested. Is this just a coincidental thing, or is there a causative role there? And it's given us an opportunity to do some workshops on that, to solicit more applications along those lines. So it's interesting. But there are lots of other things that are interesting as well. The technology to try to detect that a person might have evidence for Alzheimer's disease, whether it's looking at electronic health records or, again, driving records. So lots of things. Yeah.
And what's interesting is that what we, in the companion paper to the paper showing the increased amounts of herpes simplex virus 1 and also HHV 6 and 7 in the brain, as we showed in the same issue in a partnership paper, that herpes rapidly seeds amyloid deposition. And what we've learned is that amyloid in the brain is actually an antimicrobial peptide that's protecting the brain against low-grade subclinical infection. So as soon as the amyloid beta protein sees this virus or a bacteria, it sticks to it, and the plaque is actually made to entomb the microbe. In innate immunity, that's called an extracellular trap. So we now know that amyloid actually plays a role in the brain, and it's actually seeded by microbes. And this is another thing we can think about how to curb amyloid deposition. But we also make the point that you don't want to wipe it out, that you want to dial it down, but you know, A beta does have a role, and it's a very classic clear-cut antimicrobial peptide in the brain.
So it could be both.
Oh, sorry. I was just going to jump in just as more of the layperson on in doing the research for this. In terms of what's really fascinating is looking at what we've learned, especially about the differences between men and women and our brain health. And really a lot of the funding that's gone into that in the past few years, the increase in the number of women in clinical trials, just fascinating work about our hormones, especially perimenopause for women, and how that might affect our brain health, where I think they're finding some interesting links and things that we could do earlier to intervene, as well as we know there's just disparities with non-white populations. We don't know enough about that, but there definitely are differences, and I think the research that's coming out is just fascinating in terms of how we might look at a more precision medicine type approach, but certainly differences between men and women to reduce. A lot of people don't know, when we talk about 2/3 of the people living with dementia today are women. It's much higher risk for women, and as a caregiver burden as well. So the research that we're finding that can look at some of those reasons why and how we might be able to reduce that prevalence, I think is really exciting.
And maybe just to follow up on that, one of the interesting things, again, in the sleep relationship with Alzheimer's, is that insomnia is more specifically related to Alzheimer's than any other form of dementia, whereas other sleep problems are related to vascular dementia and other all-cause dementia. Women have a significantly elevated risk of insomnia, and when they're caregivers, they have even more insomnia. We've done studies that show that in populations that are mostly women, that individuals in their late 50s, early 60s who report more sleep disturbance but are not impaired cognitively have evidence of greater amyloid and tau deposition. So one of the interesting studies I think we need to do is to look to see if we treat insomnia, how does that potentially mitigate the progression of the disorder, and how might that affect women? And of course, women perimenopausally, postmenopausally have more insomnia, they have more depression, that are risk factors. Women have more inflammation when they have insomnia in their brains. There are some interesting associations there that might explain the increased risk for women.
And why are women more affected by insomnia? Do we know?
It's probably related to the fact that they're more at risk for depression. Sort of the evolutionary aspect of depression is, at least the theory is that depression makes us a little bit more sensitive to our conspecifics, our friends and our family, and women are the more empathic sex in general, and so there may be some adaptive features for women being more depressed. Also, people who have depression tend to be a little bit more successful in other studies that have been done. So, yeah, we're a little bit more vulnerable, but we have some other advantages as well. And women sleep differently than men. Their sleep brainwave patterns are quite different.
I think we snore less.
Well, that's
what our husbands say, at
All of
least,
my
right?
women patients say they don't snore, but when we put them in the lab, they have sleep apnea, and they just
Maybe our husbands just don't
just
tell us,
snore
or
more
our partners
quietly,
just don't
yeah.
tell us. I want to talk about the caregiver role. And Nora, I know that you are a caregiver, as well as doing the work that you do professionally. Tell us about that, both from a personal level and what the work shows about the burden on caregivers and what more needs to be done to support people like you.
Sure, thank you. I mean, in the work that we've done on Alzheimer's and brain health, I think most of us recognize so many of us have a personal experience with it, and that's what's really brought us to this work. And you just see the passion in the scientists who are studying the disease, and people trying to find a cure, and people providing care. And it's born from our experience of caring for people that we love. My dad was a psychiatrist. He had Alzheimer's disease, and his 3 siblings as well had it. So our family really experiences firsthand. And I think, you know, what Rod and I have talked about, once you've been in that situation and have seen someone you love there, then you recognize really, to real what happens. And, you know, my dad was a doctor, my sister's a hospital administrator, I'm a health policy wonk. Even with all of our knowledge going into the system, we were so frustrated by the way he was treated. You know, people with Alzheimer's disease have multiple chronic conditions. Often they're being admitted to the hospital for other things, not paying attention to whether or not there was dementia, you know, being discharged in the middle of the day, calling us to say, you need to come pick up your dad, and just leaving him in a hallway. You know, I still have that image, you know, in my mind of my father in a wheelchair in a hospital, waiting for someone to come pick him up. And to me, it's just, you know, we really need to do a better job. We've been failing people who are living with dementia and their caregivers. It's incredibly stressful for everyone. I think there is hope. We're looking, and, you know, is it payment systems that we're trying to change, and we advocate for some of these to really, there's some innovative models coming out of CMS that will, for example, pay paramedics to stabilize people at home. Because right now under our system, they only pay ambulance systems if they take you from your home to the hospital, which creates all kinds of issues in the emergency department. It's one of the most stressful places for families and caregivers and the people living with dementia to be. And data out of San Francisco found 70% of people being admitted to the emergency department with dementia don't need to be there. So we need to look at new solutions that really help families, can stabilize them at home, save the system money, but also, most importantly, provide better quality care to people living with dementia.
And Dr. Hochman, you know, running so many hospitals and of course representing the Hospital Association, the people who work in hospitals are incredibly stressed out. Obviously, they've got a lot to do. But how do you ensure that there is empathy for people with Alzheimer's in really every condition, but just to make sure that people don't feel kind of abandoned like that.
Sure, I think there are two parts of it. You got to redo the health system. So it can't just be big institutions. And I think what we're learning as we're trying to take care of the changing demographic is that smaller, lighter ambulatory settings, outpatient settings, are really where a lot of this work has to occur. So what you'll see with a lot of progressive health systems, they're kind of redoing the way they're set up, so that I would hope that your dad wouldn't even have to come into the hospital. If they needed to go somewhere, they could go to a smaller ambulatory setting, more comfortable, easier to deal with, and that's kind of the big transition that's going on. The second part of this is on the caregiver side. So when we look at the workforce in healthcare, we've got to redo the workforce. So we need caregivers that we're training that are specifically designed and trained to work with the elderly, to work with folks with neurodegenerative disorders. So there's a big task force that's looking at the workforce of the future in healthcare that needs to be significantly different than it is today. And it isn't just about doctors and nurses, it's all the alternative caregivers. Because if anyone has had their mom, dad, brother, it's incredibly isolating. And it's all on you, and you don't have that ongoing support that you need to do. So a lot of that also has to be, we have to train a whole cadre of caregivers to help the families and the patients that are out.
I'd like to just note that we have also been supporting a lot of research looking at care and caregiving. There are a lot of models out there that have been tested in various settings, but not necessarily well generalized or disseminated. So we've asked the Agency for Health Research and Quality and the National Academies of Science, Engineering, and Medicine to do a kind of a state of the science review of where we stand on models of care that are ready to be disseminated. And first draft of that report will be available this March, just before our next Care and Caregiving Summit that'll be held on the NIH campus. So that's something to look forward to. I'd also say that we recently funded an initiative called the Impact Laboratory that's looking at a group of health systems coming together and doing what's called pragmatic clinical trials, embedded trials in a health system to see, what you're suggesting going to truly be effective across multiple sites? Are there other ways of doing this, better ways of doing this? So we're excited about that as well, because yes, if we get a cure tomorrow, there are going to be millions of people still living with this illness. So we have to be prepared on all fronts.
And as progress is made toward that potential cure or treatment, there's not nothing we can do now. I mean, there are things that we can do. So let's get some news you can use for everybody in this room right now. And I'd like to ask everybody, if you're going to give advice, what can you do, or what advice should we be giving our family members about the best way to keep ourselves healthy? And I'll start with you, Dr. Benca.
Well, obviously get plenty of sleep, but more importantly, make sure that any sleep disorders are identified and treated. Sleep medicine is one of the newest fields in medicine, and it's only been the last couple of decades that we started to recognize what an epidemic we have of sleep disorders. In the older population, 20 to 40% of people have obstructive sleep apnea and other forms of sleep apnea, which are fragmenting sleep and causing brain hypoxemia, which is going to exacerbate not only Alzheimer's disease, but a lot of other things that contribute to Alzheimer's disease. Insomnia, again, is a big risk factor, and these are things that can be treated. And sleep is so important for brain health in general. It's not just if you're at risk for Alzheimer's, but if you want to preserve your brain health the best you can, you should be sleeping an adequate amount and on regular hours. So that's the first and foremost health message I have.
How do you do that in today's society? What are your tips for making sure you can get adequate sleep, and especially for people who are insecure in insecure environments, things like that? It's very difficult.
Oh yeah, those are kind of larger issues, but I kind of like to give people advice about sleep the same way we give advice about diets. You're not going to be perfect every day. But the key is to make sure that most of the time you're getting enough sleep. So we know that the effects of sleep deprivation, for example, or sleep restriction are cumulative. So having day after day after day where you're getting not quite enough sleep is going to be cumulative in terms of its effect on your brain health and your brain function. So, you know, try to schedule some days during the week where you can have some downtime before you have to go to sleep and get to bed early. And particularly with busy families, I suggest, you know, everybody should have an early to bed night.
How much should we be worried about kids getting enough sleep? You know, there's a big debate now about starting school later and how that does lead to better performance sometimes.
There are some wonderful studies that have been coming out. I'm from California now, where Governor Newsom just signed the law that high school cannot start before 8:30 in the morning. The data show that when in school start times that are 8:30 or later, that kids get way more sleep than any school time that starts earlier, and their function during the day is better. And you know, adolescents and kids in school have some what we call social jet lag. Some of us who work have that too, which is you're getting up early during the week, but you're really staying up late, and then on the weekends you go to bed late and you sleep in hours and hours extra. And that's associated with poorer school performance, more mental health issues, and kids who don't get enough sleep, of course, are at greater risk of developing depression, anxiety, and other, and certainly substance abuse disorders. So sleep is really, really important for the developing brain, and adolescents need more sleep than adults.
What would be your advice, Dr. Bernard?
Well, I hate to be Debbie Downer, but I have to talk about the evidence review that we, again, asked the Agency for Health Research and Quality and the National Academies of Science, Engineering, and Medicine to do a State of the Science review that was reported out in 2017 about whether we were ready for a public health campaign for prevention of Alzheimer's disease, mild cognitive impairment that often precedes that, or just plain cognitive decline that occurs with aging. And during that very comprehensive and thoughtful review, reviewed by a panel of experts, the conclusion was that we were not yet at the point that we could do a public health campaign about that. The level of evidence was not high enough, although there was very encouraging data about the benefits of exercise, the benefits of blood pressure control, and possibly cognitive training. And there has been, since that time, other evidence that's come forward to reinforce those sorts of things. There was a study called the Mind study that just came out this year that showed that in people with high blood pressure, going for a goal blood pressure of 120 versus 140 was associated with, they didn't meet their primary endpoint of decreasing dementia, but they met secondary endpoints of decreasing mild cognitive impairment and mild cognitive impairment plus dementia. Very encouraging. And there are a lot of other things that are out there, combinations of therapies, diet, exercise, cognitive training that are encouraging. So the conclusion from that study was that what's good for your heart may be good for your brain, and I certainly know that most of the neuroscientists that we fund are living by that. So I would say that's what I'd recommend.
So I worry, I wake up every morning worried about the health of the country. So just beyond just what we're talking about here, you know, we're living in a Western country that's seeing a decline in its life expectancy. And if we just do some of the things, there's great science out there, but a lot of us just wish we would do the things that we know work. And those are things around diet, those are things around an epidemic of type 2 diabetes, those are an epidemic of depressive disorders and mental illness. So we have a real emphasis on saying, let's, you know, even before we can prove the science, let's just do some of the things that we know work in our population and really get at preventive care. Because with all that we're spending in the United States on health care, we're still lagging behind many of the other developed nations in an embarrassing fashion. I think we duke it out with Costa Rica every year in terms of what our, you know, a status of our health status is. So I'm a big believer that this will have a benefit as we're talking about neurodegenerative disorders, but we've got a lot of work to do as a country just looking at our general health.
Do you think that hospitals are moving in the right direction to facilitate preventive care?
Not fast enough. We've lagged behind. You know, if you look at the morbidity and mortality rates amongst women, I mean, it came out in USA Today. You know, it was pretty embarrassing to look at those rates of morbidity and mortality in moms. So I think there's still more work to do. We tend to be enamored as a country with these great breakthrough kind of high-tech things, and less so with the just basic stuff that we have to do in the clinics and in the communities and whatnot. So I think overall I'd like to see more of that, and I think it'll be helpful.
You know, I'll just not repeat what folks have already said. It's all very important. I just add a few things, and we try to summarize what the available evidence is in our report. But, you know, don't smoke. You know, it's like, as Rod said, it's things that we know that really have an impact. Exercise more. It's good for everything in our health. It's certainly not going to have. Two things that weren't mentioned that I will is hearing loss, which is a risk factor for dementia and not screened enough in our country, and people that don't get hearing aids are becoming less expensive, but tremendously help your overall health. And also social isolation, which I think has become, you know, everyone's become more aware of that impact on our brain health in terms of at risk for mental health disorders, but as well as dementia as well. And so really much more effort to bring together across generations, people interacting with each other and having that social engagement, which there's evidence to show that that's really good for your brain health.
Dr. Tansey, I know you just testified about this to a Senate committee.
Well, everything's been said. So, I mean, I agree with everything that's been advised. So we just started at Mass General, speaking of what hospitals can do, the McCann Center for Brain Health, which is specifically on promoting brain health and not just doing remedial medicine, but teaching folks how to prevent disease and be resilient. Henry McCants is also the chair of the Cure Alzheimer's Fund, and very active in Alzheimer's research. So to summarize what we just heard at a Senate testimony that I did last month for the Special Committee on Aging, I used an acronym of SHIELD, shield your brain. So S is sleep, H is handling stress. We didn't mention much about stress, but handling stress or meditation practice. I is interaction with others, social engagement. L is learn new things, cognitive training. D is diet, Mediterranean diet, mind diet, taking care of your gut microbiome. But, you know, back to, you know, your comments, Dr. Bernard, about where's the proof. I think that now that we have 2.7 billion hopefully coming for Alzheimer's, given that pharma companies aren't going to do trials on sleep or exercise or diet, I'm hoping that we'll see a new wave, and we're hoping that our center will do this, of trials that really put the proof in the pudding and say sleep does work, exercise works, diet works, so that now we can go out and tell people, here's the evidence, it really works, you don't just have to trust us. And hopefully we're going to see that happening over the next few years with NIA help.
Almost half of our trials are focused on non-pharmacological interventions. Much
Wonderful,
right.
wonderful.
Just a few seconds left. You know, that goal by 2025 of a cure or treatment, I guess, for Alzheimer's disease. Do you guys think it's realistic? We're going to get there?
I think we can do a lot more in this period of time. We might not cure it, but we should be able to have a significant impact.
Mm-hmm. I would certainly say that if ever we were positioned to do so, we are well positioned. There's so many different directions that the research is going, and it's not putting all of the hope in one particular intervention. And we'll have to see how the science evolves.
I think we'll understand the complexities more. It's the same evolution that we had with the understanding of cancer, that it's much more complicated than we thought it was. So I think what we'll do is have a much deeper understanding of the complexity of neurodegenerative diseases.
I'm very optimistic. I think, you know, with trials going on, I'm involved with a company doing a phase 3 trial on a neuroinflammatory drug, AZ therapies, that also moves amyloid. I think if we remember that amyloid is early, if you want to help a full-blown patient hit neuroinflammation, the phase 3 trials are already going, and there's some very promising drugs out there. So I think the next couple of years are going to be very interesting, and I remain very optimistic.
Well, thank you all for the work that you do and for joining us this morning. Thanks, everybody.